Let's discuss the answers only. Yeah.
So this means that 46% have given this answer, answer C.
So next.
Here, can I comment?
Yes, sir. Yes, sir.
Right. I think here again, when we were discussing about the proteinuria, again a single line statement we all should give to all of our colleagues that the presence of proteinuria is just for the diagnostic sake and it has no role in management at all.
Yeah.
It's only that. Okay.
Right.
Thank you, sir. Thank you.
And even if proteinuria is absent, but other signs of severe preeclampsia are present, like less than 1 lakh
Platelets.
Yes,
or
madam.
pulmonary edema,
Yes.
then even then that will be called a
We should. Yes, madam. Agree.
Next. Martin, second question. Yeah.
hypertensive disease or pregnancy contributes to
completely.
what percentage? Yeah, almost. Yeah, we do agree. This is the answer.
60%. Yeah. Yeah.
Which of the fetal congestion in pregnancy is complicated by preeclampsia? So, 61 have given answer fetal growth restriction. Yes, fetal growth restriction is the commonest complication. Patient with preeclampsia has a diastolic blood pressure of 95 millimeter. Then 1 plus proteinuria. She complains of flashes of light in front of her eyes and upper abdominal pain. Which of the following grades of preeclampsia should be at this? Should be?
Put her.
Should you put this patient? So 92% have given preeclampsia with severe features. So why the severe features? Because when the patient complains of flashes of light in front of her eyes, that is very, very important. And it is a clear harbinger and indicator of ongoing eclampsia very quickly. So in fact, our patient should not come into this stage.
Yeah.
We should have given magnesium sulfate prophylactic before that. So the answer is right, preeclampsia with severe features. Which of the following women has the highest risk of preeclampsia? So as Dr. Gorak has said, and sir has included in his gestation score also, chronic hypertension is the commonest, highest risk factor for preeclampsia. And almost all have given, 57% have given the right answer. What is the most common cause of maternal mortality in preeclampsia? Here people do mistake. Here 30% have given the answer intracerebral hemorrhage. Yes, intracerebral hemorrhage is the commonest cause of severe preeclampsia. That's why everybody is saying, Dr. Gorak sir has also emphasized on the fact that magnesium sulfate has got different role and antihypertensive has got different. मैग्नीशियम सल्फेट आपको कन्वर्जन रोकने के लिए देना है या कन्वर्जन के ट्रीटमेंट के लिए देना है, एंटी हाइपरटेंसिव फॉर decreasing the BP, and this antihypertensive will prevent death from intracerebral hemorrhage. Am I right, Dr. Gorak sir?
Yes, madam, absolutely right. और यही लाइन जो मैंने बोला था कि पहले हमें सिखाया गया था कि सिर्फ डायस्टोलिक ब्लड प्रेशर पे ध्यान दें, लेकिन अभी all guidelines have said that कि both are important, systolic as well as diastolic. Agree, ma'am.
Drug of choice for managing severe gestational hypertension. So 96% had given the right answer, labetalol. Labetalol is the drug of choice, easily available है हमारे यहाँ, and contraindication everybody knows, bradycardia होता है, congestive
cardiac. डॉक्टर गोरख की बात याद करो कि क्या हमने इस आशा वर्कर को सिखाना है, आपका पल्स रेट अगर आपका ज्यादा है,
yes,
पर यहाँ पे मैं एक लाइन बोलना चाहूंगा कि लैबेटोलॉल हमने बोला है, दैट इज फाइन, लेकिन यहाँ पे अगर आईवी लैबेटोलॉल लिखा होता तो फाइन. सीवियर जेस्टेशनल हाइपरटेंशन, ओनली थिंग मैडम ये है कि अगर हम पेरिफेरी सेटलमेंट देखें तो वहाँ पे इवन नेफिडेपिन इज आल्सो वन ऑफ द ड्रग ऑफ चॉइस, because with labetalol, IV labetalol, we have to do the preparation. They should know the dosage, they should know the regime 20, 20, 40, 80, 80. So it is again here I will say कि I'm sorry but I will contradict here, and I will say कि at peripheral level nifedipine tablet plain should be the first drug of choice, and in IV labetalol in the settings where monitoring facilities are available. So I will balance that.
I wish to share one knowledge that methyl dopa has been withdrawn because of the liver toxicity. आपको हमने उसकी गाना नहीं गाना gynecologist को anymore. It was liver toxic and that's why it has been withdrawn.
Correct.
Sir, I have one question here.
जी.
There are three preparations of nifedipine. One is intermediate release, one is immediate release, and one is sustained release.
Correct.
जो books कहती है ASOG guideline and other guidelines, even WHO, that you have to give immediate release nifedipine in case of severe hypertension. Immediate release preparation इंडिया में मिलता नहीं है, तो उसमें आपका क्या ओपिनियन है?
इमीडिएट का
Correct.
मतलब
मैडम,
प्लेन
जो
वाली,
अपनी-
अक्सर प्लेन मिलता है.
हाँ,
प्लेन वाला.
मैडम जो अपना प्लेन टैबलेट मिलता है,
हाँ.
even if you see the onset of action for that is 8 to 12 minutes.
10 minutes है प्लेन वाले.
Yes,
10 minutes.
it is 8 to 12 minutes, so that is sufficient. So I think that we should use.
It's better that it comes under Government of India guideline.
Yes, madam.
है ना, वो उसके लिए हमको कोशिश करनी चाहिए.
कोशिश करना पड़ेगा.
तो next question. A woman with history of severe preeclampsia in her previous pregnancy has come to NCOPD at 9 weeks of pregnancy. What treatment has been shown to reduce? ये तो बहुत बार हमने डिस्कस किया है. I think इसमें भी 98% लोगों ने करेक्ट आंसर दिया है. जो भी एस्पिरिन
देना है.
बेस्ट आंसर. अब डोज 75, 100, 150 whatever. But basic answer is aspirin देना है. ये ज्यादा जरूरी चीज है.
नहीं, लेकिन मुझे लगता है
और कब देना है? Before 11 weeks देना है.
करेक्ट. लेकिन मुझे लगता है कि हमें ये बात बोलनी शुरू करनी चाहिए कि 75 मिलीग्राम.
ठीक है
Because
सर.
it is very clear. Even all pharmacology books and all, they are saying कि 75 is safe.
Right.
Right, sir. What percentage of women can develop eclampsia before overt proteinuria? तो हमने पहले भी बोला था कि proteinuria is not that important for making a diagnosis of a case of preeclampsia.
जी.
So here 18% have given the
28.
correct answer. Answer is 10% of women develop severe preeclampsia without proteinuria. Severe preeclampsia is defined as BP more than 140 or 90 millimeter of mercury after 20 weeks in previously normotensive women, along with all except.
बराबर.
Pedal edema, yeah.
So the answer is pedal edema. Pedal edema 80% pregnancy में normal होता है. So pedal edema is the option.
But again, madam, the answer here is again disturbing because almost 12.7% of the people still have said that कि creatinine more than 1.1. So that is really upsetting.
सर हियर आई विल से आपने एक बार मैक्सेल सुन लिया ना कि 25 लोगों ने 300 में से बोला कि मैक्सेल उन्होंने यूज नहीं किया. नाउ वी हैव टू रब पीपल, rub in people's mind what you have said. Your one slide has to be the only presentation. We have to all have to learn that particular slide.
I agree, ma'am.
Incidence of postpartum eclampsia.
Yes.
So 31%.
We have written 10%. Dr. Anita Rajoria feels it is 30%. हमें एक ही बोलना पड़ेगा. बोलिए क्या 30% लिखना है कि 10% निकला है?
सर ज्यादा अच्छी तरह बता पाएंगे इंडियन स्टैटिस्टिक्स. Yes.
It is 10 to 10.2%. Yes, it is 10 to 10.2%.
Yeah, 10. The statistics in the book is 10.
So matlab we have to be basically very vigilant in postpartum period.
Yes,
that is also the
postpartum
important
period
message.
as well.
Next. All are risk factors for the development of preeclampsia except prior preeclampsia, chronic hypertension, diabetes and BMI less than 18. ये सर के जेस्टस स्कोर में से आंसर है इसका. 96% have given the correct answer. Obesity is a risk factor, not low BMI. The initial loading dose of IV plus IM of magnesium sulfate in the treatment of eclampsia is
14.
So it is 14 gram, everybody knows, and I think 92% have given the correct answer. So my concern is towards those 8% who have not given the correct answer.
Absolutely.
They must know that it is 10 plus 4, and as sir has said that 4 can be avoided where only nursing, or where only the Anganwadi worker or Asha worker are using this at very extreme remote peripheral areas. Otherwise, the dose is 14. in normal pregnancy, when does the remodeling of spiral arterioles begin? So here again, the sir's concern that it is the timing of aspirin when it is to be given. It is not the dose. Though dose is important, but it is timing is more important. So we have to know the timing when the spiral arterioles.
So that means our answer is very clear here. We have to start.
Yeah, sir.
Yes, madam. As you are rightly said, answer now will be very clear that we have to start the aspirin before 10 weeks.
Yes. Very clear. Or if somebody has started it earlier, no problem.
No problem.
It should not be started later. That is the message.
Absolutely. Absolutely.
So the maximum oral dose of labetalol in 24 hours as antihypertensive is
24.
76% have given the answer 2400 milligram. Yes. So sometimes what happens, we do not increase the dose. So you can always increase the dose. There is no fear.
So only madam,
Maximum
one
cumulative
line.
IV dose of labetalol in 24 hours is 300 milligram. Government of India guidelines says 220 milligram. Here 55% have given the correct answer. Most of the time, patient does respond with 220 milligram. Very rarely we have to increase it to 300 milligram. But the message is that you should be able to give, you should know about this, and you should be able to give up to this dose. There is no fear. The following are contraindications of IV labetalol, except this is very important. We are using labetalol right and left, so we should know the contraindications. So 73% have given the answer maternal tachycardia. Please come to.
It is the right answer. Yes.
Yeah. Question 18. Active asthma, heart disease, and congestive heart failure are contraindications. So everybody should just learn this by heart. Question number 19. If there is a contraindication of labetalol, suppose patient has bradycardia, then the initial dose of oral nifedipine should be
10, always 10.
2% have given the right answer. Sir has also said 10 milligram of nifedipine. And sir has also said that we should use the intermediate release nifedipine for this, as immediate release nifedipine is not available in our country.
And here
No
again,
sublingual. No sublingual, please. Yes.
Sublingual is out. Sublingual
Yes.
is out.
and one line here, I think we have to add. We should tell everybody. Okay, first dose is being given, then wait for 20 minutes.
Yes.
And if again we can repeat it again after 20 minutes. Again we can repeat after 20 minutes. So each 20 minutes we have to add the 10 milligram.
Right.
Till
Sir.
the maximum dose reaches 60 milligram. That we have to convey.
Yeah, can I speak something, please? Just one.
Right.
observation.
Yeah.
It has been observed in our hospital also. Even if we give, this labetalol, after giving the third dose, if the BP is not coming down, we shift to oral nifedipine and we find that the BP is controlled.
Madam, it is also written in ASOG guideline also that with the third dose,
नहीं,
patient is
आप
not
लगे
responding.
मत रहो एक में, आपको चेंज करना
Add on कर लीजिए. Yes. Add on कर लो. Add on कर लो is a better option.
In fact, nifedipine के साथ भी थर्ड डोज के बाद आप ऐड ऑन कर सकते हैं मैडम.
Right.
It is like this.
इसीलिए मैं एक लाइन कहना चाहूंगा मैडम अगेन. दो हमने लिखा है कि ओरल लैबेटोलॉल 2400, लेकिन इन अवर गाइडलाइन इवन वी हैव सेड दैट कि जब 800 मिलीग्राम से ज्यादा डोज बढ़ाने की नौबत आती है,
Add
तो आइडियली वी हैव टू ऐड द अनदर एंटी हाइपरटेंसिव देन इंक्रीजिंग द डोज ऑफ मोर देन 800 मिलीग्राम. सो लाइकवाइज निफेडिपिन के बारे में इफ 40 मिलीग्राम से ज्यादा डोज बढ़ाने की नौबत आ रही है, तो वी हैव टू ऐड ऑन द सेकंड एंटी हाइपरटेंसिव,
Right, sir.
because these are the guidelines for adding the second anti hypertensive.
Right.
Over to you.
So,
Hello, sir.
question 20.
Right.
Hello, sir. One of my patient is hypertensive. She is known case of asthma.
Right.
She was on labetalol at periphery. I shifted her on Nicardia, but on second visit, her pulse rate was 128.
Correct.
Now what to do?
Now, again there is a problem.
You can give
Because
labetalol.
that patient will present with later on with headache, and we will be confused whether that headache is because of HDP or it is because of the nifedipine, because already the pulse has crossed 120.
Yeah.
But in such cases, again, the safer approach. This is I am anecdotal talking, not for the guideline. Here again, the safe approach will be amlodipine.
Yes, yes.
So please check the
Means,
another variant of the nifedipine.
I have one suggestion, sir. Suppose if her pulse is, madam, if her pulse rate is increased to 120, and if the bradycardia was the reason for not giving labetalol initially, so you can add labetalol also.
No, she said she had a
Asthma.
asthma.
He is
Asthma,
non-case of
okay.
asthma.
Ah, she was asthma. So that was.
But she was tolerating it well. There was no episode, no?
No, she was not tolerating labetalol. She said, I
Okay.
have perspiration with labetalol.
Okay.
I
Okay.
started Nicardia. She, no problem with Nicardia. But her
Correct.
pulse rate was 128.
Right.
Oh.
Right.
Now what to do? I have some queries.
No, madam, we can definitely shift on her to amlodipine and please check.
Okay.
But
She is
sir,
now 32 weeks.
amlodipine causes tachycardia.
But madam, the CCBs, the more tachycardia is caused by nifedipine, then nicardipine, and then amlodipine.
Sir, I have one more question. As WHO has written in the guidelines for managing non-severe hypertension, can we shift this patient to alpha-methyl dopa?
Definitely,
Not
if it is
available.
available.
Not
If it is
And
available.
alpha dopa is gone in the garbage. It will never come back again because it has been withdrawn for good
Yes.
for the liver toxicity.
Okay.
Sir, can we give tablet metoprolol in such cases?
The guideline, the metoprolol and all these things are not allowed actually. So again, and again there will be a question of ethics, and then we have to take a special consent. We have to consult with the ethics committee and or the physician, and then we have to go ahead. So in very anecdotal cases, I think we have to do all these things.
So this is again a beta blocker. Metoprolol is
Doctor,
again
go
a beta.
ahead. Adna, सारे लोग चले जाएंगे. Go ahead.
Right.
Okay, so the last question is indication of resuscitative fluids in preeclampsia. So 45% have given the correct answer. Answer is concealed hemorrhage, where we need to give the resuscitative fluids.
Here again, I would like to add one
Yes,
line
sir.
that we have to discard the 5% dextrose from our practice, obstetric practice.
Yes, sir. I agree.
That I agree.
Yeah, that
बिल्कुल
is not a
लेबर में
fluid.
रहना ही नहीं चाहिए. कहीं पर कोई
Yes. नहीं
emergency
चाहिए.
dextrose में
वो
रहना ही नहीं
हमारी
चाहिए.
practice में
fluid है,
होना ही नहीं
useless
चाहिए.
fluid है,
Only
sir.
NS and RL, and that's it. And no other practice in obstetrics, I'm saying. At least we
Yes,
are
yes.
keeping that.
और यदि कुछ और नहीं समझ में आ रहा है तो खाली आरएल को याद रख लो. That is more than sufficient.
बिल्कुल शशि. Even normal saline से prefer करते हैं. आज का रिंगर में भी अगर sepsis में भी बात करें.
Disbalance हो जाता है तो remember RL only. That's the
Yes.
first.
Next.
Go ahead.
Why not under spinal anesthesia?
What?
Alina?
Anesthesia.
Over to you.
I'm
Dr.
just
Vandana.
asking why not under spinal anesthesia? Because we know that the intracellular, the compartments are constricted, but generally they do. Although we are giving epidural, that is the favored anesthesia of choice.
No, they were not discussing
So
anesthesia.
option
They were
था ना?
Spinal की
There
बात
was
ही
an
नहीं हो रही थी,
option
spinal की
there,
बात
ना?
है.
नहीं,
Was an option
हम
in
एनेस्थीसिया
the
की बात नहीं, हम IV fluids
Yeah,
की
yeah.
बात.
I just wanted to know because it's there in the option and 40% have ticked that.
Which
Dr.
one?
Lina, resuscitative fluid is not given in spinal anesthesia. Resuscitative fluid only in
Okay,
concealed.
okay.
ये लोड देते हैं ना स्पाइनल में, वो
वो नहीं
PQ
देना.
केस में नहीं देते.
Yeah.
नहीं देना.
So the rate.
Okay, the word is resuscitative. Right.
Extra load. We are giving extra load.
Extra load, yes.
Yeah.
Dr. Vandana,
Then you have to resuscitate the patient when the patient has lost fluids.
Yeah.
So that is concealed hemorrhage. The rate of fluids in the post-op cases in preeclampsia, 53%. Nearly half of them have given 1 to 1.5 milligrams per kilograms per hour. So
Right, you have
that
to restrict the fluid. You have to restrict the fluid.
No, ideally it has to be 80 ml per hour. It is
हाँ
very
सर
simple.
उतना ही आ गया ना. अगर 50 से 60 किलो
आता है.
तो उतना ही आ
यानी
उतना
it
ही आ
should not
जाएगा.
cross 2.4 liters per day.
Yes.
That is very important.
okay. Fine. Next. So pulmonary edema in preeclampsia presents most commonly in which phase of the pregnancy?
Postpartum.
Postpartum. So 55% have given a right answer. It is postpartum. Next. Mississippi classification for HELP syndrome is based on which following criteria? Except that is haptoglobin level.
Yes.
That is so platelet count is taken, LDH level is taken, and liver functions,
GOD,
liver enzymes are taken. They are taken into account, but not haptoglobin levels.
Yes.
Next. Which of the following biomarkers is not used in first trimester screening for preeclampsia? So they all are used. PAPE is also used, PLGF is also used, SFLT, but now we are using only gestosis score. So, so that would be the from here. The following condition will be diagnosed as preeclampsia, hypertension greater than 140 or 90, with the proteinuria presenting before the start of pregnancy. The correct answer is proteinuria presenting in the second half of the pregnancy, although proteinuria is still not the criteria. Which which statement is not true with regards to preeclampsia? That proteinuria occurs often after edema and hypertension. This is not the sequence.
Correct.
So it can occur at any time, and hypertension definitely would be there, but edema not necessary. Next. Eclampsia is life-threatening emergency and occurs when? So we all know that it occurs after 20 weeks of pregnancy. And 72% have given a right answer. Next. Which is not accurate with regard to the management of eclampsia. So in this question, the option, all the options are correct rather. I had asked for this option to be corrected. Magnesium sulfate does not lower BP. This is right. It does not lower BP. So the option should have been magnesium sulfate lowers BP, not does not lower BP.
But they have given the right answer.
Yeah. They've given the 45% have given the right answer, but magnesium sulfate does not lower BP and it is not used as an antihypertensive. The message is that. Next. Which would be consistent with the seizure due to eclampsia that responds to benzodiazepines. Next. Eclampsia rarely occurs without hypertension. It's true.
True.
Yeah. Next. Which type of eclampsia has the worst prognosis? Antepartum and 37%. There are many who have said postpartum, but in antepartum, there are two people at risk, the mother and the baby both. So the eclampsia with in antepartum phase has the worst prognosis. Next. Malti, next question.
In fact, patient will improve after delivery. That is for sure.
Yes. No, but many people must have considered that postpartum eclampsia, although it has a different etiology, that's why it is bad.
Yeah.
Occurrence of fits associated with PET during labor or within 42 days is eclampsia unless proved otherwise. It's a false statement, and the answer is within 7 days. Occurrence of fits associated with PET during labor or within 7 days is eclampsia. So next, not 42 days. So only 84% have given the wrong answer. So be careful, take home messages. It has to be within 7 days. Next. Cause of convulsion in next. Cause of convulsion in eclampsia, definitely it is cerebral anoxia due to arterial spasm. And 98%. So that is nearly 10%. Right. That's good. Next. Occurrence of fits associated with PET during labor or within next. Ye to pehla wala aa gaya. Next. 35. Maternal mortality in eclampsia in North India is 5%. So this percentages, people definitely would know or not know. Ye most likely people have just ticked by the I think the hitch. So 56.3%. Okay, next. It's a common cause. The commonest cause of death in eclampsia in India is pulmonary edema, and that is the right answer. 64% have given the right answer. So antihypertensive of choice in pulmonary edema is nitroglycerine. So we had attended a class on critical care, and this was the take-home message. So good, 70% patients, 70% people have given the right answer. World Preeclampsia Day is on 22nd of May. So all should know, only half the people know. It's on 22nd of May. It's a global Preeclampsia Day. And DGF and NIGF eclampsia mortality booked Bharat Call is in December 2005. So rest of
sir, we have written down that this is our aim.
Yes, madam.
Right. People were asking me. I said, RCOG guidelines padhte ho, DGF guidelines padho. Vitamin D supplementation during pregnancy is recommended to prevent development of PET. No. So that is a false answer. So only 20%. Rest said yes. No. Vitamin D supplementation is not for prevention of preeclampsia. So sir has already said only low dose aspirin and calcium, antihypertensive at the right time, low carb diet, and magnesium, and then early referral. Thank you. Last question, Acha. Using Mexelf in all cases. So in that is severe preeclamptic toxemia and imminent eclampsia. Yes, all of the above. So you have to use Mexelf in all. Here we say that we have to use Mexelf as a preventive measure also when we are referring a patient.
Dr. Gorak, I just wish to share with you is that we said severe PET में तो देना ही है, but I think I saw in US they gave to my daughter Maxhelp after cesarean section, and they gave it for 24 hours, and her BP maximum was, once it was 150 by 100, otherwise 140 by 90. So they said for us PET is Maxhelp we have to give.
Okay.
So they were as clear as that.
That's why
No,
I'm saying
we are also giving, yes.
what has happened now, madam, what in our conferences, what happens in day-to-day conferences, many people say many haywire things, and that's why probably the things have gone wrong. Otherwise, as you rightly said, the things are there since beginning कि बाबा 1, 2, 3, 4 and 5.
नहीं सर, ये क्विज कराने का खाली मतलब यही है कि जो वेग चीजें आपके दिमाग में है, प्लीज कम एंड लर्न द करेक्ट आंसर.
जी मैडम,
ये मैं आपको भेजूंगी अगर आपको कुछ इसमें और करेक्शन करना है या किसी को कुछ स्टेटमेंट देना है, बिकॉज द पीपल हु आर टेकिंग अ क्विज एंड आंसरिंग इट, दे मस्ट रब इन देयर माइंड कि ये करेक्ट आंसर क्यों है, व्हाई द अदर 3 आंसर्स आर नॉट करेक्ट.
नॉट करेक्ट.
सर आपको इनवाइट करने से पहले हम लोगों ने ये इंटेंशन की थी, and all people who are here definitely feel after your presentation, one slide presentation, it is doable. So I want every chairperson should definitely speak whether it is doable or not doable.
Doable, ma'am. And we have a gathering of more than 85 people.
Yes, ma'am.
Doable, madam.
We decide it is doable.
It is doable.
Yes, yes.
It is doable, ma'am.
Doable.
Anybody who is here, please want to speak, please speak whether it is doable or not doable.
It is doable.
You have to give very clear message only this time.
After a long time, I have heard a presentation which can go on for 40 minutes with one single slide.
One single slide.
Very nice presentation.
Very nice.
Sir is an encyclopedia, yes.
सर मैं आपको यहाँ पर एक छोटी सी बात बताना चाहती हूँ. I left medical college and I went for adolescent health workshop in a very prestigious school here in Delhi. So one gentleman, Dr. Ashok Kumar, asked me, I was the team leader. So he asked me कि डॉक्टर साहब मुझे बताओ आप क्या बोलने वाले हो. I looked at him कि आदमी मुझसे क्या पूछ रहा है. उसने कहा नहीं डॉक्टर साहब, आपको आज प्रिंसिपल साहिबा हैं और 150 उनके टीचर बोलने वाले बिफोर दे लेट यू गो टू द स्टूडेंट्स. तो आपने डॉक्टर साहब बहुत ज्यादा बात नहीं करनी. डॉक्टर साहब आपने आपसे रिक्वेस्ट है, आप मेरे से, मेरी मदर की एज है, पर आपने 5 पॉइंट्स बताने डॉक्टर साहब, और उसी में घूमते रहना है. So this is what I like about it of your one slide presentation is you should be that clear कि आपके पास बस 7 चीजें बोलनी है, इसके अलावा कुछ नहीं बोलना. So you reminded me of Dr. Ashok Kumar ki he told me, Dr. Jain, आप फालतू बात मत करना वहां पर. So my hats off to you, sir. It was great presentation of yours. After a long time I've heard so.
ये ब्लेसिंग है कि आपके मुंह से ऐसे आ रहे हैं, अदरवाइज मैं बहुत छोटा हूँ. थैंक यू.
बस छोटा नहीं, आपने, लेट मी बी वेरी फ्रैंक विद यू, अगर आप जैसे लोग लग जाएंगे, ये जो कॉल है आपने दी है कि 25 तक एक्लैम्सिया की डेथ्स नहीं होंगी, आपने तो कॉल ये भी दी है कि 25 तक आपकी खुद के बुक केसेस के अंदर आपको एक्लैम्सिया नहीं होगा. हम लोग बाहर के लिए परेशान नहीं हो, लेट्स नैरो डाउन. हमारे बुक केसेस में एक्लैम्सिया नहीं होना चाहिए, जो कि 40% of the gynecologists have said they have had eclampsia in private practice. And 90% of the government sector people have said their booked cases have had eclampsia. So one thing. And then mortality तो होनी नहीं. Mortality तो बाहर से भी आए उसकी भी mortality नहीं होनी.
मैम
Ma'am, I had one yesterday.
Yeah, you told us about
I
it.
had one yesterday.
हाँ मैम, ये जो गवर्नमेंट सेटअप में मिला है ना, इसमें गैप हमें कहाँ पर मिला ज्यादा? पेशेंट आते हैं, दिखाते हैं, एंटीनेटल केयर में बुक होते हैं, देन दे आर लॉस्ट फॉर फॉलो अप. They will come again with severe features. That is a big issue. So these secondary delays and these are very, very relevant as far as
no aspersion. But ये जो 6 question का quiz है, it is eye opener.
Yes.
दिल्ली जैसी जगह में 24 लोगों को मालूम ही नहीं मैक्सल क्या होता है.
प्लस जो जेस्टोसिस स्कोरिंग है वो नहीं हो रही है ड्यूरिंग द एंटीनेटल पीरियड एंड हाई रिस्क फॉर प्री एक्लैम्सिया इज नॉट बीइंग मार्क्ड ऑन द
एंटीनेटल. आप अपने अस्पताल में कर दो, अनीता अपने अस्पताल में कर दे, सब लोग अपने अपने अस्पताल, झरना इज सिटिंग इन हियर, अपने अस्पताल में कर दो, अपने उनके रब कर दो. हमने एक बात बिल्कुल क्लियर है सर, वी आर गोइंग टू डू on the 21st of May. We will have one physical meeting where only 50-60 people will be there. All presentation will be there. I will send you the copy of the same. And उसमें जो भी फालतू की चीज है उस सर आप उसको निकाल दीजिएगा. क्योंकि now today I've realized कि ये फालतू की चीज बोलना नहीं हमें. We should be clear so the other party also should be clear. And then we get the whole thing recorded and everything will be sent. We'll make 100 leaders. एंड दिल्ली में ये कोई कह नहीं सकता कि जी हमें मैक्सल माता नहीं था, हमें मालूम नहीं था कौन सा एंटी हाइपरटेंसिव देना है, हमें ये मालूम नहीं था कि क्या चीज क्या होती है. हमें ये 7 चीजें रटा देनी है उनको. वो सोते भी उनको हिलाएंगे ना तो बोलेंगे कि
बस बिल्कुल 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 ऐसा ही होना चाहिए.
ऐसे ही होना चाहिए. सच में ग्रेट.
ग्रेट ऑनर फॉर डॉक्टर गोरख. आपका एंथुजियाज्म खत्म नहीं होना चाहिए.
नहीं कभी नहीं. Thank you so much, madam.
Today 80+ people had joined at the peak time and I think
सर मैडम हीरे को परख लेती हैं.
नहीं, इसीलिए मैंने बोला कि it is a blessing for me कि बाबा thank you so much. Really I am very much happy and definitely
डॉक्टर शशि हमने आपको भी परख लिया था सर मैडम.
Okay. The weather has turned pleasant. यहाँ पे आंधी आ रही है. Enjoy that. Okay.
Thank you so much.
Thank you so much.
Bye bye.
We are ready to hear. Let more and more people hear about
Right.
this one slide talk. I will see to it that 2 months later again you present.
Yes.
Yes.
Thank you.
Right.
Bye.
Bye bye.
Bye. Thank you.
Bye.